Ramesh, I think you can stop sharing the screen, I think, for a
Is it so?
Yeah.
Okay. Right.
For 2 minutes for the introductions and all, no? So,
Manoj, you can start now. I think it's already.
we usually wait for 100 people to reach to start. Do you want to do that, or maybe
I
one
think-
or two more minutes will?
Yeah, we can wait for another 5 minutes, not an issue.
Although Ramesh and Sun do not wait for anything. They rise at the same time.
Thank you. It's better.
Manoj, I think we can start off with the introductions and the thing, no?
Yeah,
I
yeah.
think
In the
we-
Yeah, I
meantime,
think
sure.
so. It's already 5 minutes past. So let's start. Hello, everyone. Good evening. As we come to the close of this transformative NNF course all about sepsis, it's a moment for us to actually look back and reflect and probably plan our days ahead. We at NNF have been so much humbled by the kind of response we had in the registrations, in the participation in the LMS, and of course in the way the interactions are going on. But as we always say, all good things need to come to an end. So we are this is going to be the last of the lecture series. And of course, we end the course with this. This course has been more than a course. That's what I would like. It's a collective journey through the complexities of neonatal sepsis. We all know it's a condition that continue to challenge clinicians and compromise outcomes across the country. At the outset, I would like to thank each one of you delegates who engaged, asked questions, and shared your real world struggles. In fact, this course is richer because of your voices. Hope you have benefited from this course as we wanted you to. We all know our country is so heterogeneous that we cannot have one protocol in place all over. And our scenarios are different in each and every area, even in a single state. So it is for us to understand these basics all about sepsis and then adapt and then keep interacting. I would also like to thank all our respected faculty. Thank you, all of you, for challenging us to think beyond guidelines towards innovation, early detection, and antibiotic stewardship, and so on and so forth. And finally, special thanks to the organizing committee headed by Dr. Sridhar, Mamta Jaju, and then ably coordinated by Dr. Abby Matthew, Dr. Nelby George, and all the whole team. Thank you so much for making this course a reality. We already have a lot of requests to rerun this course for others who could not join. Friends, let's continue to lean on each other, learn, collaborate, and innovate and find what is right for you in managing this dynamic problem in your setting. So finally, thank you for being part of the journey. Together, we are not just improving outcomes, we are redefining neonatal care and attempting to reach the unreached through these initiatives. Let's stay inspired and connected. Thank you. Thank you so much. So now today, we have a great session, the final session on responsible use of antibiotics, know your antibiotics. And to moderate this session, we have two eminent personalities, Dr. Sanjay Wazir and Dr. Vijendra Kumar Garg. So I hand over the session to Sanjay and Vijendra. Over to you.
Thank you, Manoj. And it's a privilege to be here today. And it's a privilege to listen to Ramesh, because every time I listen to him, he comes up with something which is brilliant, and more importantly, it is brilliant and simple. So to begin with, I would talk every time we write an antibiotic order in our NICU, we make a choice. Sometimes life-saving, sometimes habit-driven, and sometimes just blindly guided by fear in the night that the child would deteriorate in the morning. But I mean, we need to stop somewhere mid-round and ask ourselves, why are we starting meropenem on this baby? Or maybe the question that, do I really know how this drug behaves in a 28-week baby? Am I choosing the right dose, right duration, and right combination? These are some of the questions that I think Ramesh would discuss over the course of this talk. And in the end, I would say that in a world where the tiniest patients face the biggest threat from both infection and resistance, as we have seen in most of the studies which have come, Dennis and other studies from Delhi NCR, knowing your antibiotics is just not a good practice, it's also a critical responsibility. Antibiotics are like fire. They can protect, but they can also burn. So it's important we understand the power, the limitation, and how to use them wisely, and who better to guide us than Dr. Ramesh. Dr. Ramesh is the professor of pediatrics, professor of neonatology in All India Institute of Medical Sciences. I do not think any neonatologist, fellow, or professional who would not have heard about him or his great work in neonatal sepsis. Over to you, Dr. Ramesh. Ramesh?
You have to unmute, Ramesh.
Good evening, everyone. And thanks to Sanjay, Dr. Manoj, NNF leadership, Dr. Sridhar. And truly, it's a great initiative. Unfortunately, I couldn't do my talk on time, and it happens to be the last, though it should have been in the middle. My sincere apology for that. Dr. Manoj made a very important point that we need to learn basics and then build upon that. So that captures the essence of my talk. That when it comes to knowing your antibiotics, then my talk is going to be a primer. So understanding the issue of antibiotics, and many of you who are in this profession for long time would agree with me that we were managing antibiotics. There were few handful of antibiotics. We knew about it, the spectrum, when to use, how to use. But with this emergence of AMR, things got very, very complicated. And you must have some glimpse of those complication in the previous talk in the management of MDR sepsis. And I'll step back and just try to touch upon the basics. This is the first slide, and I really liked about this statement that when we talk of antibiotics therapy, then it's not just the drug. It's the drug, the bug, and the mug. So these are the three things that we need to know. And when we talk about the drug, then we need to understand what is this drug and what is the spectrum, what is the PKPD, pharmacokinetics and pharmacodynamics, whether it is safe, and cost is also very important. And similarly, when we talk about bug, when we have a sepsis syndrome.
Ramesh, your screen is not shared, I think.
Oh, is it so?
Yeah.
Yes. Please.
So I'll unshare it and then do it again.
Yeah, I think it is.
Oh, right. Yeah, you're right. It's not shared. Is it visible now?
Yes.
Right. So this concept of drug, bug, and mug is a very important one, because it's not just the antibiotics. We need to know about the basics of this trio. And when it comes to the drug, we need to understand what's the spectrum, what is the pharmacokinetics and pharmacodynamics, whether it is safe or not. And the cost is very, very important. Similarly, when it comes to bug, we need to understand that for a given sepsis syndrome, what could be the possible culprit? And with emerging resistance, we need to have a realistic idea what is happening in our unit with respect to resistance, and not all the units may be the same. What is the site of infection is also very important, because antibiotics may reach there or may not reach there. And similarly, the bug, the host, there are several factors that are different from a pediatric patient or an adult patient, and there are rather too many variables to consider when you are thinking of antibiotics in neonates, including gestation, postnatal age, organ function or dysfunction, comorbidities, like if you have PD, the thing changes a lot. The concomitant therapies, the baby is on hypothermia, then the drug dynamics would change. So therefore, it is really very important that we listen to the bug, honor the drug, and above all, respect the fragile mug, who must carry them both. And unless we take care of all these three different stakeholders, we may not be able to make the best decisions for the patients. The objectives of this conversation, some 45 minutes or so, would be knowing your antibiotics. Again, I would like to emphasize the basics, spectrum, some bit of mechanism, the tissue penetration, the side effects. I haven't though talked much about it, and some glimpses on dose, administration, dilution, etc. The pathogen profile, AMR pathogen profile as it is prevalent today in different studies, the patient-related factors, and finally, how to make choices with regard to antibiotic therapy. Coming to the first objective, the drug, this looks a complex slide, but this tells you that how antibiotics emerged. And the thing started early in 20th century. And then there was a period which was known as golden period, and several antibiotics were discovered. And this was followed by a period of lull wherein the antibiotics were not coming, and whatever antibiotics we had, we were losing them very fast. But fortunately, in last 10 years or so, with the global attention, there are more antibiotics that are coming into the picture. And of course, we are now thinking beyond antibiotics also. However, when it comes to the neonates, we are not going to talk about many antibiotics. In fact, we do not have too much of access to the newer antibiotics, because the research in newborn often lags um, lags behind pediatrics or the adult patients. We are going to talk about penicillins, aminoglycosides, tetracycline, quinolones, glycopeptides, carbapenems, polymyxins, macrolides, and linezolides. So first, coming to penicillins, one large group of antibiotics is beta-lactam antibiotics, and penicillins are the very basic ones. And the penicillins could be different types: the simple penicillins, or the anti-staphylococcal penicillins, or broad-spectrum penicillins. We have first generation penicillin G, or the crystalline penicillin, or anti-staphylococcal penicillin like floxacillin, the common one. Then we have broad spectrum second generation like ampicillin and amoxicillin, or third generation like ticarcillin, and fourth generation like piperacillin. Importantly, we tend to use third and fourth generation, which act against beta-lactamase producing organisms such as Proteus or Enterobacter and Pseudomonas also. However, there is emergence of resistance. They achieve good therapeutic level in pleural, pericardial, and peritoneal fluids. However, the penetration in CSF is poor. But in meningitis, they are yet able to achieve a good concentration so as to achieve therapeutic cure. Here, important point is that for the sensitive Staphylococcus aureus, anti-staphylococcal penicillin like floxacillin or cefazolin would be better than vancomycin. This is an important message that we should remember. Coming to the second beta-lactam group of antibiotics, cephalosporins, and we have several generations. First generation, second generations like ciprexime or cefamycin, or third generation like cefotaxime, ceftriaxone, ceftazidime, etc., and fourth generation and fifth generation. While the first and second generation are primarily acting against gram positives, but third, as we move towards higher generation, we have increasing gram negative cover. And they are broad spectrum antibiotics, though we are losing them very rapidly. The another antibiotics that we hear these days is the aztreonam, not a new one, but we are using it more commonly now. This is active against Enterobacteriaceae and Pseudomonas. However, there is no activity against gram-positive organism or anaerobes. And Acinetobacter is inherently resistant, and Pseudomonas can become resistant during therapy. And it is important to remember that the spectrum is similar, but they are less reliable to aminoglycosides. So therefore, when we need to treat Acinetobacter or Pseudomonas, choosing an aminoglycoside would be better than aztreonam. The next group of beta-lactam antibiotics is carbapenems. Carbapenems, they are really broad spectrum. They cover gram-positive, but important to remember that they do not cover MRSA, methicillin-resistant Staph aureus. They cover gram-negatives, many beta-lactamase producing Enterobacteriaceae group and Pseudomonas, and they also cover anaerobes. There is good CSF penetration, so therefore they can be used when you have meningitis, and this is choice for MDR sepsis, provided that the bug is sensitive. Need to remember that imipenem we do not use in neonates because they can cause seizure. So therefore, use meropenem instead of instead of imipenem. The next group of antibiotics, which has been mainstay for long time, is aminoglycosides. And I will be talking about these three agents only that we use commonly, namely gentamicin, tobramycin, and amikacin. Amikacin is the most important one. They are broad spectrum and they cover primarily though gram negatives like Enterobacteriaceae, Pseudomonas, Acinetobacter, and H. influenzae. They have poor activity against organism like gram-negative organism like Burkholderia, Strenotrophomonas, Maltophilia, and anaerobes bacteria. They do cover gram-positive. They are active against Staphylococcus aureus, but they are unreliable for that. So therefore, they are not recommended as monotherapy. And they have low activity against pneumococci, and they have no activity at all against enterococci. Enterococci are in fact inherently resistant to this thing. Other important thing is that avoid using it longer than 10 to 14 days because they can cause ototoxicity. And also, if the neonate is receiving hypothermia or has come very hypothermic, then there is that decreases the renal clearance, which is the principal mechanism of their removal, and that can result in increased serum level and toxicity. Therefore, adjust accordingly. Aminoglycosides are good because they are stable against development of resistance during treatment. But unfortunately, many MDRO, multi-drug resistant organism, like those was producing ESBLs or carbapenemas, then they are resistant against aminoglycosides also. The most frequent use is often in combination with other antibacterial agents as empiric therapy for serious infection like sepsis or nosocomial respiratory tract infection or complicated UTI, or even bone infection against aerobic gram-negative bacilli. We have high concentration in urine, but they have poor penetration in CSF. They are effectively removed by both hemodialysis and peritoneal dialysis. So therefore, you need dose adjustment in that. The other group of antibiotics that we are using commonly is the combination of BL-BLI. BL is beta-lactam, and we have talked about several beta-lactam antibiotics, and beta-lactamase inhibitors. So beta-lactamase are the enzymes that are produced by several bacteria that inactivate these antibiotics. So they may be producing, for example, cephalosporinase. And these cephalosporinases, these are beta-lactamases enzyme, they would inactivate cephalosporin, thereby neutralizing their effect. Similarly, carbapenemases, they may neutralize the carbapenem. So these are the inhibitors that inhibit these inhibitors. Inhibitors inhibits these enzymes, thereby restoring the activities of the antibiotics. And these are things like clavulanate, salbactam, tazobactam, avibactam, and then there are few that are not available with us. Important is that they do not have their intrinsic antibacterial activity. And as I said, they inhibit the enzymes and thereby restoring the activity. And we often combine them with drugs like piperacillin, ceftazidime, meropenem, or cefepime, and enhancing their spectrum of activity. The newer beta-lactamase inhibitor, BLIs, in addition, their addition to ceftazidime, like avibactam to ceftazidime, viborbactam to meropenem, result in their activity against carbapenemases, carbapenemase producing bugs. So this is, there are truly extremely resistant organisms that can, which the carbapenem antibiotics can have restoration of their activities using their newer BLIs. Coming to the next group of antibiotics, they are not coming in any order. I have just picked up the important one and trying to give you key features. Vancomycin and teicoplanin. They are active against methicillin-resistant Staphylococcus aureus methicillin-resistant conj, and enterococcus. Important to remember that they are not active against gram-negatives. And we know that vancomycin can cause Redmond syndrome, and nephrotoxicity is very important feature of vancomycin. And in those situations, one can use teicoplanin. Quinolones, again, old antibiotics, they are broad spectrum. They have excellent tissue penetration. There was concern that they do not penetrate CSF well, so therefore cannot be used in meningitis. But now the newer studies have found that they can be used even in meningitis. And there was concern that they can cause arthropathy, but they are now considered safe in neonates. Clindamycin, primarily gram-positive, but they are effective against MRSA, but community-acquired MRSA, not nosocomial, the hospital-acquired MRSA. They are effective against anaerobes. They have got excellent bone penetration, so therefore they can be used in bone infection. And good thing is that there is an oral drug available also. We know metronidazole, it is active against anaerobes, good CSF penetration. Important thing about the metronidazole is that this drug get metabolized by liver and no renal excretion. So we need to be careful when we have hepatic dysfunction. Linezolid, again effective against MRSA, vancomycin-resistant Staph aureus, and vancomycin-resistant enterococci. So very important drug. Again, oral is available. It can cause myelosuppression, particularly thrombocytopenia after 7 to 10 days of use. And it can cause neuropathy after very prolonged use, like 4 to 6 weeks of use. That can be there when we are using it for treating bone infections. Therefore, it should be used as a reserved drug. Cotrimexazole, again, effective against a variety of gram-positive and gram-negative bacteria, but MRSA, community-acquired, not hospital-acquired. And this is active against these newer organisms like Burkholderia and Stenotrophomonas multifida and Serratia also. But Pseudomonas, anaerobes, and pneumococci are resistant to Septra, and the resistance can develop during therapy. Coming to polymyxins, this include two drugs, colistin and polymyxin B. They are good drug for MDR, hospital-acquired gram-negative infection, Klebsiella, Acinetobacter, and Pseudomonas. Important to remember that they are inherently resistant. The bugs like Proteus, Serratia, Providentia, Brucella, Burkholderia, they are inherently resistant, so you don't use them. The other important thing is that they have got poor penetration in CSF, bone, and lung. So therefore, when you have meningitis or osteomyelitis or VAP, then they are not useful. Colistin, they achieve good urinary concentration, but as I said, they have poor CNS concentration. And polymyxin B, good thing is that good or bad, whatever you say, is that there is no renal excretion. So therefore, it is not effective in UTIs. Tetracycline, generally contraindicated in neonates and infants because it can cause pseudotumor cerebri, teeth discoloration, and retardation of skeletal growth. We have two important drugs here, minocycline and tigecycline, though FDA does not recommend them children below 8 years, but it can still be used in MDR sepsis as an off-label use. Now, this slide actually summarizes everything. Unfortunately, this looks scary, but don't worry about it. What I want is that if you can take a color print and use it when you need it, then that would be a better use to that would be a better thing to do, because otherwise it would be difficult for you to remember. But it serves as a very good reference. Here you have As the column heading, you have the antibiotics, and these are the different bugs. Here you have gram-positive bugs, and here you have gram-negative bugs. And these green cell means that, for example, MSSA, methicillin-sensitive Staphylococcus aureus. So these are the antibiotics that would work against them. So you can see that for some bugs, they are sensitive against many antibiotics, while things like Enterococcus, you have fewer antibiotics. And then you can see it this way also. If a particular antibiotic is effective against a variety of organisms, that means that's a broad spectrum antibiotics. Compared to these antibiotics, for example, they are covering less and less cells, so therefore there are narrow spectrum antibiotics. And then you have these cells. They are telling you that the mode of elimination of antibiotics, largely it's renal for all the antibiotics except few like cefoperazone, like clindamycin, like doxycycline or tigecycline and metronidazole. For the remaining drugs, it's primarily renal excretion. So therefore, if you have renal dysfunction, then you'll have to modify the doses. And the drugs that are excreted or metabolized through hepatic route, you'll have to take care of those antibiotics when there is liver dysfunction. Similarly, you have CSF penetration, and the these pink colored cells show that these antibiotics achieve good concentration in CSF. For example, amoxicillin, cefotaxime, cefepime, and so forth, metronidazole, fosfomycin, and you can see colistin is not achieving good concentration in CSF. So the antibiotics that are achieving good CSF penetration can only be used in meningitis. And the third row is dose modification. So if you have these disorders, then there are methods to do it, but you need to modify the doses. And the yellow colored cell shows the partial sensitivity. So this would be a very good chart, and you can navigate. So this is third generation cephalosporin. You can see that they are effective against gram positive and gram negative, but not against MRSAs. Similarly, you have piptaz, broad spectrum antibiotics. You have meropenem, carbapenem, again effective against most of the bugs, gram positive, gram negative, but not effective against MRSA. These are vancomycin, teicoplanin, linezolid, clindamycin, etc., primarily effective against gram positive, except clindamycin, which covers anaerobes also. Tetracyclines, again, except tigecycline, these two drugs are relatively narrow spectrum. These are fluoroquinolones, effective against broad spectrum of bugs. You have aminoglycosides, you have ceftazidime avibactam combination, you have fosfomycin, you have colistin. So take your time. I'll share this presentation with you, and you can print a nice A4 chart and keep it for ready reference. This is the another chart that you need to know. I have just flipped this chart here. The columns show you the bugs, and the rows shows you the antibiotics. So, for example, if you have MSSA, then what are the different antibiotic choices you have? If you have, for example, Klebsiella, then what are the different antibiotic choices you have? So again, these two charts you can print and keep it for your ready reference. Right? Now I'll take you to this very important concept, which is known as time-dependent killing versus concentration-dependent killing. So this is the chart which x shows you time and y-axis shows you the drug concentration. When you give a dose of drug, when you inject a drug, it achieves peak concentration, and then gradually concentration comes down. And then a certain level would be what is known as minimum inhibitory concentration. So you want antibiotic concentration to be above that for the antibiotics to act against the bug. So there are antibiotics that are time-dependent killing, like beta-lactams. And here what is important is that for how much of time the drugs stay above the level of MIC. So therefore, in these situations, the infusions are better because that allows the antibiotic to remain above the level of MIC, thereby increasing their efficacy. There is another important thing which is known as concentration dependent killing. And here, what is important is the peak concentration of drug, as in aminoglycosides. So here you have peak concentration, and especially for aminoglycosides, you have what is known as post-antibiotic effect, wherein the after giving a dose, the effect persists even when the concentration of the drug is not there that much. So these are the drugs, particularly again aminoglycosides, where OD doses are more important than multiple doses because the low concentration are responsible for toxicity like ototoxicity or nephrotoxicity, while efficacy is dependent on the peak concentration. So OD dose would be better. Now I switch to another important issue. It is not just the spectrum or the efficacy, but you need to know about the administration related issues also, like reconstitution of the drug as per the recommended strength dilution, and you need to pick up the right kind of diluent. Often normal saline or dextrose water would work for most of them. Similarly, reconstituted drug would have a defined shelf life. Don't go beyond that. Then there may be some dosing specifications. For example, colistin is expressed in terms of milligram as well as IU. Make sure that you don't confuse. Similarly, when you talk about piperacillin tazobactam, the doses that you see is that of piperacillin, not both the drugs together. Similarly, you have teicoplanin that needs 3 loading doses before maintenance, or aminoglycosides that are given once a day. And it is really very important that the nurses are well oriented and then syringes are appropriately labeled so that they are aware of the final strength, diluent, and time of preparation so that there is no error. In fact, the dilution and administration and drug errors are pretty common and may be a reason for lower efficacy or lack of efficacy or even serious side effects. We need to be very careful about that. Coming to our the bug issue, here I'm going to show you 4 charts and take you through them quickly. This is a Danish study, 11 to 14 pre-tertiary care hospitals, inborn patients. And these are the organism Klebsiella, Acinetobacter, E. coli, Pseudomonas, and then these are gram positives. And you can see the gram positive almost half to 3/4, 1/3 to 3/4 of them are methicillin resistant. Here, just pay your attention towards multi-drug resistance. You can see half of the Klebsiella, majority of the Acinetobacter, and nearly 1/3 of E. coli are multi-drug resistant. Coming to the outborn cohort, the previous slide was inborn cohort. Here, the magnitude of resistance was even higher, and the MDR figures for the bugs corresponding MDR corresponding figure for the MDR for these bugs is considerably higher, and similarly for gram positive also, the methicillin resistance is much higher. This is a recent study conducted at district hospitals, and I'll not take too much of time. Just say that we found that the resistance level was quite high, even level 2 hospital SNCOs. Third point, the mug, the neonate. And I'll just touch upon the few factors like absorption issues. They have lower gastric pH and immature enterohepatic circulation. So that can increase absorption of drugs. The same drug can result in higher level. The plasma protein binding. Majority of the drugs would have certain degree of plasma protein binding. But in neonates, they have decreased affinity and decreased levels. So therefore, the increased unbound drug would be there, and unbound drug is responsible for its effect and toxicity. So they are at higher risk of toxicity. The body composition. The neonates tend to have higher total body water compared to the adults, and they have more extracellular fluid, less muscle mass, and less body fat, and that would result into increased volume of distribution or low volume of distribution, affecting the drug level compared to the adults. Similarly, the metabolism, hepatic metabolism and renal metabolism is different in neonates, predisposing them to the toxicity. Renal excretion, again, GFR, tubular secretion, and reabsorption is immature. So drugs like amikacin and vancomycin are likely to cause more toxicity. And the diseases like PDA, they can result into fluid retention, can alter the drug concentration and decrease the efficacy. And when the PDA is closing, then the drug's concentration can go up and can cause toxicity. Need to be careful about these issues. Coming to the next objective, that how do you make your empiric antibiotic therapy? And I don't know, I share my own experience. At some point in time, I used to think that empiric means arbitrary antibiotics, that you don't know anything, so therefore you don't give anything. That's not true. Empiric means it's an evidence-based antibiotic therapy. When patient comes to you and you do not know what's the bug, but yet it's evidence-based. And how do you do that? This is, this is reiteration of what we were showing, the resistance pattern. And here, these are different studies pooled together, and these are 3 antibiotic regimes. This is meropenem, carbapenem based regime. These are 3rd generation cephalosporin based regimes, and these are penicillin, gentamicin based regimes. And this is the efficacy. So you can see that the efficacy of all these regimes across the studies have been very low, signifying that the penicillin, gentamicin based or even cephalosporin based regimes may not be uniformly effective. So we really face a very difficult situation, and I'm quite sure you all are aware of it. So how do we formulate antibiotic policy? So there are 2 important aspects. One is the empirical therapy, and you have to send blood culture in a proper manner before starting antibiotics and get the result, putting the right amount of blood into it so that you get the result. And once you get the result, then you need to optimize your empiric therapy. The empiric therapy is dependent on your own data, local antibiogram, your own units data. You cannot take anyone else. And optimization, once you have, then you do targeted therapy for the de-escalation. So what are the steps to formulate antibiotic policy? You use your unit antibiogram. You make simple tables and then see that to which antibiotics your bugs are sensitive to. And based on that, you choose 1st line or 2nd line antibiotics. So you collect data on your pathogen, maybe in last 6-12 months, you have to have some number of bugs from your own unit. And then you tabulate them for each pathogen in a Microsoft sheet, Excel sheet in this manner. So you enumerate the bug, each one of them, and these are the antibiotics, and you say that they are resistant or sensitive. So that at the end of it, and you can do it separately for gram positive and gram negative, because you would have different set of antibiotics. So you would get to know that, let's say you had 3 enterococcus, that how many of them are resistant to amikacin and how many of them are resistant to cefoxitin or vancomycin. So you get to know that what is the status of your enterococcus faecium or MRSA or E. coli or Klebsiella, right? And then you tabulate in this manner that you have antibiotics here, and then you have your organism. Let's say you had total of 17 growth of staph aureus. Then you get to know, you tabulate them, and then find out that how many of them are sensitive to cefoxitin or coamoxiclav or ciprofloxacin or amikacin. Similarly for the gram negative. So you would now know that what proportion of your bugs are sensitive to what antibiotics. And similarly, then you combine antibiotics and then see that what proportion of your bugs are sensitive to which antibiotics. And then based on the 5-6 common pathogens that you encounter, you choose a combination of antibiotics that would cover your 60 to 70% or 80% of your bugs. That would be your first line antibiotics. Then you would choose second line antibiotics that would cover additional 20 to 30% of bugs, or the bugs that are not covered by first line antibiotics, that would give you second line antibiotics. You can say that I don't have blood culture, so what do I do? The answer is that collect the unit data. There is no other alternative. You can use regional and national data in the meanwhile, but the step 2 should not go on all the time. When you get your culture, and by this time you have clinical course and you know whether the baby has responded or not responded, whether the sepsis symptoms were suggestive of sepsis, how much of the time that has taken, is there any alternative explanation, and of course culture. And then accordingly you de-escalate your antibiotics to narrow spectrum. Suppose you started let's say piptazoamicacin, and you found that your bug is staph aureus, which is sensitive to cefazolin. You stop these two and go to cefazolin. Or you find that you have started cefazolin, let's say piptazoamica and vancomycin, thinking because baby was very sick, but you found that it's an E. coli which is sensitive to piptazo. You can continue piptazoamicacin and stop vancomycin, and so on and so forth. So therefore, key messages are that understand not only the drug, but also the bug and the mug. That's very important. Understand your antibiotics, have your basics clear, and have some document at hand, which you can consult again and again. Be aware of the resistance patterns of the bugs at your site. And what are the, for a given baby, what is the site of infection? Understand the patient and have an antibiotics policy that is based on your data. Thank you. Yes, over to you.
Yeah, thank you, Ramesh sir, for this wonderful presentation and for nicely explaining all the things about antibiotic, how to choose rational antibiotic, empiric antibiotic, and your drug, mug, and bug concept. You presented this topic very well. That no questions till now from any audience. We are waiting for questions. If any question, then we will take one by one. Meanwhile, when we have questions, I just want to know what empiric antibiotics you are using at AIMS Delhi, sir.
I think that answer to that question is meaningless.
Yeah.
So, we all face the same problem. And currently, our first line antibiotics is piperacillin tazobactam with amikacin. Okay. And if there is shock concomitant shock, then we tend to add vancomycin, and then of course look at the culture and course of the baby and decide the subsequent regime. But as I said that, each unit is different.
Yes.
So therefore, you have to have your own data.
Sir,
And
we have
also a very important message is that these days it has become very difficult, and it was perhaps always very difficult to treat infection. So therefore, focus your energy in a big way on prevention of infection, and infections are eminently preventable.
Thank you, sir. Now we have questions from Vidya Ramadas. How is peptide amikacin is superior to meropenem? Nothing else is right. Just how is peptide amikacin superior to meropenem?
I think if you look at the spectrum of the drug, it's not too different. But you have different patterns of resistance. I don't know whether you can see my presentation. Is it visible or I have unshared it?
It is not. It is not.
Right. So you see that peptidoamicacin yeah, so it is side by side, and you see that except few bugs, for example, Burkholderia and Strenotrophomonas, these are covered by meropenem, but not by piptazole, right? And MDR, again, piptazole has developed resistance to it, but meropenem has also, but might be better than piptazole. So meropenem is little better coverage, and has retained its efficacy more than it depends on the given bug. So more or less they are the same, except few differences.
Dr. Ramesh, if you'd allow me, can I add one point?
Yeah.
Sridhar here. I think, just expanding on that topic, just for everybody, I think Dr. Ramesh and I also were discussing this last time. You should remember that many of the beta-lactamase inhibitors may not cross the blood-brain barrier. So if you have a resistant bug and there is meningitis, the tazobactam may not cross the blood-brain barrier, and so piperazine may not actually act, though your blood culture says that this organism may be sensitive to piperazine and tazobactam. So that might be one of the few things you have to remember. If there is a CNS infection, then the piperazine and tazobactam in an MDR infection may not work. Just to keep. Sorry, Dr. Ramesh, and thanks.
Yeah, no, I think that's a very important point. So therefore, if you have CNS infection and bug is sensitive to piptazole as well as meropenem, it's better to use meropenem.
Next question is how to approach a sepsis with Stenotrophomonas maltophilia with suspected meningitis.
Depends on the sensitivity that you get.
Yeah, but most of these are multi-drug resistant, Ramesh, and we understand that they have inherent resistance to beta lactam as a aminoglycoside. The only one of the drugs which is mentioned in literature is Septran. Would you suggest using it for any if the drug is sensitive to that only? I mean, organism sensitive to that, because this is one of the questions that arose in one of the other forums also. So I didn't have the answer.
I'm quite sure this topic must have been covered in the previous talk by in the MDR, Dr. Sridhar.
We did not cover Stenotrophomonas because we went through, I think, ESBL, Enterobacter, Carbapenem resistant Acinetobacter, and Enterobacterales, MDR, Pseudomonas, and so. But yeah, just it is a little bit of.
So it's a tough call, and one can perhaps use it. I don't have, we haven't managed many Strenotrophomonas. Maybe Dr. Sridhar can give his opinion.
No, I'm sorry. Even I haven't managed a newborn, so I think we'll need to look into what has been used for newborn. I'm not sure.
Next question is, when culture is showing resistant to antibiotics but baby responding, what to do?
You can consider continuing the antibiotics. So you have biological plausibility. You are not giving an antibiotics to which the organism is inherently resistant. So it can be sensitive, and but the in vitro results is showing resistance, but baby is responding. So you can continue, but always keep your mind open and keep your antenna very high. Because that response may be just due to supportive care, but it's reasonable to continue while keeping a strict watch.
It is. Does it apply to Pseudomonas also? Because this is like, Pseudomonas may be tricky sometimes, like, and not give you kind of a time to go back and say clinical sensitivity for milder organisms may still be okay, but for lethal ones where we do not have, would you still say in vivo sensitivity will still kind of.
I guess it also depends on the baby. Let's say the baby is not too sick, and CNS infection was not there, and the baby has shown improvement. I guess it's reasonable to continue with antibiotics. But if the baby is sick and though has shown some response, it may be reasonable to switch to the antibiotics to which your culture sensitivity is showing, showing the sensitivity.
Next question is, in most NICU data
Dr.
regarding
Sridhar, would you agree?
Yes, Dr. Ramesh. I think we've had this thing many times. I think every one of us has our different thing. We sort of said this, but just keeping in mind what Dr. Sanjay Basir said, sometimes if the baby is deteriorating and it becomes a legal problem, then that is going to be an issue. So in that way, that also has to be kept in mind. But generally, when the baby is becoming well, there might be a discordance between your in vitro sensitivity and your in vivo response due to many biological. That's true.
I think I can see Sanjay's point that he is very concerned that this is Pseudomonas with very bad outcomes. So whether we take that chance? I guess for mild, for a baby who's known sick and no CNS infection, might be reasonable to continue with the same antibiotics with a strict watch.
Thank you, sir. Next question is, if bug is sensitive to multiple antibiotics, should we use monotherapy or at least 2 drugs?
You can use monotherapy. Use the narrowest spectrum. And there is hierarchy of that spectrum. I didn't include that in that slide. Maybe I can include and then share it with you. Then use the narrowest spectrum, and you can use monotherapy.
Next question is, for taking our own unit data, we should review our culture reports for how many durations, means how many time periods?
So more than time period, it's important that what is the number of bugs that you have, right? So you should have some 20, 30 organisms to be able to make sense out of it. So you would have some 5, 6 common pathogens, and then you have to have maybe 6 to 10 of them to be able to see a pattern and to decide your antibiotic therapy. So if you get that in 6 months, then 6 months is enough. But if you get it in 2 years' time, then you might have to use 2 years data also.
Yeah. Next question is, can we use colistin as monotherapy if culture showing intermediate sensitivity to the bug?
Normally, in my understanding, colistin is it is advisable not to use colistin alone. because emergence of resistance can happen. So it's better to use with some other antibiotics.
Next question is case of MDR E. coli.
Dr. Sridhar, interrupt wherever you have something else to add.
Next question is case of MDR E. coli sensitive to Genta, but after starting Genta, baby not responding. How to proceed?
One, see for the cause of non-response. So it is possible that one is that many of the sick babies, even with sepsis, though the disease, the infection is cured, but yet they do not respond. The second is that there may be other comorbidities. There may be issue with supportive care. And of course, the bug may have become resistant. So you should definitely repeat culture and consider change in antibiotics also.
Next question is many times ball sample in intubated babies shows the growth of multiple organisms. Which one to consider pathological?
BAL is a very problematic thing, as in it often represents colonization. It's polymicrobial. So there is no clear guideline, though pediatric colleagues would be using BAL, and sometimes we also have when pushed to the wall. But BAL is a very tricky stuff. One is that even if you have one organism, whether or not to treat, it's very debatable. Better is not to rely too much on it.
Next question is can we use higher antibiotic as empirical therapy in case of outborn baby in government hospital, as mostly baby presented in sick situation without documentation of previous antibiotics?
Again, and even in outborn unit, you would have certain areas from which the patients are coming, from a nursing home, from another hospital, or from a community. So one is that it is dependent upon the fact whether there is, even if you have no idea what kind of antibiotics the baby has received. If the baby has stayed in the hospital, good likelihood that the baby has hospital acquired infection, compared to a situation where the baby is coming directly from the community. So that would be very important factor. And then secondly, over period, you should have good understanding that the baby is coming from this area tend to have this bug and this kind of resistance pattern. And again, based on that data only, you'll have to make judgment.
Next is mirocolistin has synergistic action. So can we give this in late onset sepsis despite culture showing resistant to colistin?
If the culture is showing colistin, then why would you like to use it?
There are no role.
If the bug is resistant, then there is no point of giving antibiotics because it's not going to work. It is only adding to toxicity. If you have sensitivity, then better is to combine it with, cephalosporin or carbapenem in particular, to prevent resistance happening to colistin.
Which antibiotics can be considered in aspiration pneumonia if culture is negative? Usually culture are negative in these cases.
If it is aspiration only, then aspiration is not infection.
Yeah.
So it treats infection, not aspiration. If you have infection, then of course, infection can be superimposed. And if you suspect that this is infection based on poor urine secretion or, markers of inflammation or culture report, then you use antibiotics empirically and then modify as per your culture report.
Next question is in MDR bug, except Venco, which is used for meningitis if culture is showing all antibiotics as resistant.
MDR bug?
Except Venco, all antibiotics are resistant, which is used. Only Venco is sensitive and all are resistant.
if it's a gram positive and if it's sensitive to vancomycin, I presume that this is either Staphylococcus aureus or Coagulase negative Staphylococcus. So therefore, you use vancomycin. The gram positives are not supposed to be sensitive to many other antibiotics. So an organism which is a gram positive organism, which is not methicillin or cefoxitin resistant, you can use cefazolin. But if it is MRSA, methicillin resistant, then you have to go for vancomycin.
Next is drug dosing is based on gestational age or birth weight?
Both.
If baby has acute kidney injury and
So
dose
just to clarify it, there are many drugs. So it's important to look at the gestation. So some of the just look at the formulary. You can use Neofex or something else, and some of the drugs are by weight. Some of the drugs are by gestation, and as gestation and weights change, you have to change the drug doses also.
if a baby has acute kidney injury and dose is adjusted based on creatinine clearance, do we need to change the dosing frequency once the AKI resolves?
Yeah, for sure. You have to go back to your normal dosing once the kidney functions have recovered.
Next is metronidazole has been damned in earlier lectures. What is your take for neonatal use, if any?
So if you are suspecting anaerobic infection, then you do. As a matter of routine, in empiric therapy, we use when there is any perforation, intestinal perforation, then only we use metronidazole, otherwise not. We haven't found anaerobic infection to be very common, but perforation, then we give, otherwise not.
Is cefazolin better than cloxacillin? We restrict third generation cephalosporin in neonates.
So cloxacillin, there is availability issue these days, I presume, and same is true for cefazolin also. Cloxacillin causes a lot of thrombophlebitis, so one can go for cefazolin for a bug which is methicillin sensitive, right? And second is what?
We restrict third generation cephalosporin in neonates. Just they are saying that.
Yeah, because cephalosporin one are very prone to uh, for the emergence of resistance. That's one, and secondly, they are broad spectrum. So therefore, cephalosporin in empiric therapy is not a good choice.
Last question is Neofex describe drug dosage based on gestational age. What about a baby born at 26 weeks and now 3 weeks old?
So use 29 weeks.
Yeah. And delegates are asking for sharing the charts which you presented.
Yeah, I'll share the presentation. I'll share it with whom? Do I share it with Dr. Sridhar with you?
Sure. You can send
Yeah.
it to me. I'll send it on
Yeah.
to the NNF admins.
Yeah.
That will be
Sure.
great.
Definitely, I'll do. I'll also give you a Word document which provides you guidance with respect to dilution, final concentration, what kind of diluents, and anything, any other important thing related to administration.
Oh, that will be great also. Yes.
Thank you very much, Ramesh sir.
Maybe Sanjay can add something.
No, I think it has been nicely covered, and I think we probably would get. So my only problem nowadays is getting tetracycline sensitive antibiotics only, and since it's a tetracycline, using that would become so because we cater to a lot of outborn babies, as most of the delegates kind of mentioned. Pseudomonas and Acinetobacter and all those the routine stuff is still a problem in most of the NICUs across. But I agree with you, this is a war which can be won by prevention, not by aggression. So you probably would need to look at how do we prevent it in the first place. But once you have a sepsis, half of the battle is already lost. So
Yeah, true. Yeah, I think that's a very important message, that it is difficult to treat infection.
Yeah,
Over to Sridhar sir for closing remarks.
No, I'll start off with this presentation, Dr. Ramesh. It was a wonderful presentation. I think you made it very simple. I really enjoyed the lecture a lot. Thank you very much. I think most of the delegates did enjoy. And I think Dr. Sanjay Basir, Dr. Ramesh, everybody emphasized this whole thing. I think I started off the series by saying that we are never going to win this war against the bacteria. The bacteria are much more smarter than us. We are never going to find out the ultimate antibiotic ever. Okay. And so therefore, you would notice that even in this lecture series, 5 of the 8 talks were concentrating on prevention, and there was only 1 talk on multi-drug resistant and 1 on viral infections. So I think, again, the message from everybody here is try to see how you can prevent infections in your unit. If you're an inborn unit, especially, I think that should be, it should be managed. If you're an outborn unit, at least try to make sure that you are not increasing the antimicrobial resistance load in your locality or so. Be responsible. So it was a wonderful experience. I hope all of you did enjoy this entire series. Again, thanks to Dr. Ramesh for joining, and thanks to all the faculty, all the moderators too. So I'll end with that.
thank you.
Thank you, and thanks to all the audience also.
And have a great stay in Bangalore.